Hello, everybody. My name is Dominik Linz from the Maastricht University Medical Centre, and on behalf of the Arrhythmia Academy, I welcome you to this short webinar on the title Sleep Apnea in Atrial Fibrillation Patients, Focusing on Integrated Management. I'm very happy to be here with two good friends and excellent researchers in the field of sleep apnea and cardiology, with Olaf Oldenburg. So he's head of cardiology of the Clemenshospital in Münster, Germany. He's one of the most experienced cardiologists when it comes to the management of heart failure in patients with sleep apnea and also in patients with concomitant atrial fibrillation. And he is and was involved in important trials and important mechanistic studies related to this field. And I'm also very happy to be here with Jeroen Hendriks. Jeroen Hendriks is Professor of Nursing at the Flinders University in Adelaide in Australia. And he set up one of the first nurse-led AF clinics in Maastricht and focuses now also particularly on the integrated care of patients with atrial fibrillation and also education of patients with atrial fibrillation. So we will have two short presentations and then also plenty of times of discussion to see actually what is the role, what is the way how to manage sleep apnea in patients with atrial fibrillation. So Olaf, please.
Good morning. I will start with my brief presentation here. And first of all, there is a little sketch how we think, in this case, obstructive sleep apnea works on the heart and on the rhythm. So you see the obstructive sleep apnea here having some immediate, intermediate, and chronic effects, and also acting on arrhythmia here. So first of all, what is the immediate effect of obstructive sleep apnea? Of course, it will cause micro and micro arousals. It has something to do with sympathetic nervous activation, with intermittent hypoxia, with hypercapnia and hypocapnia, so swings in CO2 partial pressures, and of course some very basic mechanistic stretch on the heart, and at least or especially on the atria, so by intrathoracic pressure swings. It will have some impact on systemic inflammation and oxidative stress, on endothelial and vascular dysfunction, and of course it will increase prothrombotic pathways. On the other hand, the chronic effects, of course, will be structural remodeling, so enlargement of the left atria, scar tissue within the myocardium. So we will have at least some cardiac electrical remodeling here, and of course it will have some direct impact on the arrhythmias or the rhythm of the heart. Going to the next slide, we looked into the prevalence, and previously I just talked about the obstructive sleep apnea. We looked at the prevalence in patients with documented AFib on admission. So we have a AFib in the 12-channel ECG on admission, and at the same time we have a preserved at least systolic left ventricular function with an ejection fraction more than 55%. And in these 211 patients, we did a routine 6-channel cardiorespiratory polygraphy screening. And the main thing we found here is that 40% of these patients had no or only mild sleep disorder breathing. Looking very in detail, we found only 12% having pure obstructive sleep apnea. Pure obstructive sleep apnea meaning that more than 80% of the events were pure obstructive and only 9% were pure central. But 21% of these patients had some type of mixed sleep apnea. So I think it's worth at that point not only talking about pure obstructive sleep apnea, but we also have to take care of the mixed apnea and in some cases of the central sleep apnea. What is the big data about the prevalence of sleep disorder breathing? So that the Orbit AF 1 and 2 trial, including more than 22,000 patients. But of course, as in every of these large-scale trials, there's no systematic testing for sleep disorder breathing. And there is no differentiation between sleep disorder breathing subtypes. So there is no clue about obstructive central mixed sleep apnea. But the main conclusion of these two trials is that about 18% of AF patients might have obstructive sleep apnea at baseline. But again, there's no testing, that's only taking the history or asking for a CPAP machine or something like that within these trials. Coming back to our small study here, as said, 60% of patients had moderate to severe sleep apnea. Mixed sleep apnea was the most common manifestation of sleep disorder breathing in this AFib cohort, followed by obstructive, and central sleep apnea was less common. And it's very interesting, hypopneas were accounted for the majority of respiratory events. And when we're talking about AFib, we have different types of sleep disorder breathing with paroxysmal, persistent, or long persistent to permanent AFib. So you can see the more persistent or permanent the AFib gets, the more we will see central sleep apnea and Cheyne-Stokes respiration. So I'm not an AP, guys. That's something for Dominik. And I don't know if the term of atrial cardiomyopathy is now well accepted or not. But I like this little sketch here, which tells us that within increasing age, we will have several factors affecting or contributing to AFib and AFib reoccurrence. That is AFib causing AFib here, that is age causing AFib here, but there is a lot of cardiovascular disease induced remodeling or affecting comorbidities here. And at least in that paper here in JACC, you see different targets of the comorbidities affecting the cardiac or the atrial cardiomyopathy, and at least there is obstructive sleep apnea acknowledged for at least some of these effects, which is the part of cardiomyocytes and fibrosis within the cardiomyocytes. Okay. What do we know about treatment of sleep disorder breathing and the reoccurrence of AFib? There are several small studies out here, and please allow me to pick one of the study I was involved, which is the CADHF trial. The CADHF trial was actually a study treating recently decompensated heart failure patients with adaptive servoventilation, regardless if they had obstructive or central or mixed sleep apnea. And in that study, which was a randomized controlled trial, we could see that with optimal medical treatment alone, we had a reoccurrence here, and with adaptive servoventilation, we had a change within AF burden, which was more than 30%, actually 39% absolute reduction in AF burden with therapy of sleep disorder breathing in these patients. But what about ablative strategies in OSA and non-OSA AF patients? And again, I'm not the EP guy here, but if you look for triggers of atrial fibrillation in patients having no obstructive sleep apnea and obstructive sleep apnea, you might see a little difference here, which is the pulmonary vein being the most relevant trigger of AFib, and the non-PV triggers play only a minor role. But after you did the procedure, you were left with the non-PV triggers here, and this is especially true for the OSA patients, meaning that OSA may require more than pulmonary vein isolation by getting good results of your IP procedure. This is something you can see here. So now it's getting very, very here. The blue lines, which is patients with atrial fibrillation having no obstructive sleep apnea, you will get good results by doing your pulmonary vein isolation procedure. If you have the red lines are the ones having obstructive sleep apnea at the very beginning, and the upper line represents the one you have OSA, you did your pulmonary vein isolation, and you get rid of your extra pulmonary vein triggers. So you treat the extra pulmonary vein triggers as well, you get good results. If you leave them unattached, your recurrence rate is at least not so good as before. Coming to my open questions for the discussion later on. So do we need to screen for sleep disordered breathing in AF patients routinely, unless there is a proven benefit of what we do here? And unless there is a direct consequence to ablative strategies. How we need to screen? We do have no validated questionnaires here. Is it enough to use your smartphones or wearables to screen for sleep disordered breathing? Or do we need oximetry, polygraphy, or even polysomnography to do so? Which type of sleep disordered breathing we need to treat? Is it OSA? Is it mixed sleep apnea? Is it central sleep apnea? What's the best metric or parameter to identify patients at risk? Do we need the classical apnea-hypopnea index or the oxygen desaturation index? Do we need to look for hypoxemic burden or to cycle length of the respiratory events? And in the end, what's the best treatment of sleep disordered breathing in AF? There is a couple of drugs emerging right now, at least for the treatment of obstructive sleep apnea. There is the positive airway pressure with CPAP, ASV, or bilevel. And there is neuromodulation therapies coming around the corner. So at least more questions than answer at that time, but a very interesting field to follow. Thank you.
Yeah, thank you very much, Olaf. So also, of course, for summarizing now already the questions, I think they are very important questions which we as electrophysiologists in the treatment of atrial fibrillation do not always actually consider. And this is, of course, also very interesting that you now as one cardiologist focusing on heart failure and very experienced also in sleep apnea actually address those points. I would just like to mention now 2 points and also briefly discuss this with you. So I think the first thing is you make a very clear you distinguish very clearly between central and obstructive sleep apnea. And there's of course also this discussion of this bidirectional relationship. So this particularly actually discussed, of course, in heart failure, that heart failure might also cause sleep apnea under some conditions. Do you actually think that this might also be the case in AF patients? And is there any indication that sometimes not just sleep apnea might lead to AF, but AF might also contribute to sleep apnea?
Definitely. So first of all, I think sleep apnea and atrial fibrillation, they share a lot of comorbidities. So sometimes it's really hard to distinguish which is the egg and the hen. Atrial fibrillation cause sleep apnea? Yes, I think so. At least that's true for central sleep apnea and Cheyne-Stokes respiration. So AF somehow means diastolic dysfunction, and diastolic dysfunction leads to central sleep apnea, Cheyne-Stokes respiration. That's one point. And what we have seen in all the studies using neuromodulation, the remedy system, and so on. So if you sometimes you see clear central sleep apnea, and if you treat this central sleep apnea, you demask an underlying obstructive sleep apnea. So the story is not that easy as it seems to be. Okay, coming back to your point, I think obstructive sleep apnea may lead to cardiac remodeling, and on the other hand, may act as a trigger of sleep apnea, of AFib. And AFib itself may cause central sleep apnea and Cheyne-Stokes respiration. So that's my answer here.
Yeah. Yeah, I think this is very, very important to also think about, because potentially if you have a patient with predominant central sleep apnea, the treatment of the central sleep apnea might not be the first step to do, but first maybe stabilizing sinus rhythm and taking care for the comorbidities, also like heart failure. And maybe also in this setting a little bit, we all have heard about the SURF-HF trial. So the SURF-HF trial was actually a trial in heart failure patients where predominant central sleep apnea Cheyne-Stokes respiration was present. And in this trial, it was tried to treat this central sleep apnea Cheyne-Stokes respiration. And this resulted in increased mortality and actually bad outcome in those patients treated. You mentioned now adaptive servo ventilation also in one of your studies.
It was the CADHF trial, and the adaptive servo ventilation in that trial was used not only to treat central sleep apnea, but also mixed and obstructive sleep apnea. So that might be a completely different field here. But coming again back to the SERVE-HF trial, I think that's a clear sign here. In the SERVE-HF trial, adaptive servo ventilation was very effective in treating the respiratory events, but on the other hand led to an increased mortality. So whatever we do here, we have to see the safety aspect as well. And my criticism in the field of sleep apnea is they are all focused on surrogates. So they are all focused on, are we getting rid of apneas and hypopneas and so on? But we have to see safety and at least some hard endpoints or even soft endpoints as quality of life or so. So we have to keep that in mind.
Maybe also one point concerning treatment. So you mentioned CPAP treatment, adaptive servo ventilation. Importantly, in the trial which you actually presented, this was not predominant central and Cheyne-Stokes respiration. This was actually something like a kind of mixed of sleep apnea. So adaptive servo ventilation can also treat obstructive sleep apnea and still take care for hypopneas. I think that's a very important point what you mentioned there. So it's different compared to SERVE-HF, and therefore adaptive servo ventilation might also be safer in those in this population of patients.
Sorry, Dominik, let me clarify that. The CADHF trial, the difference between CADHF trial and the SERVE-HF trial. CADHF was done in recently decompensated heart failure. First, recently decompensated, not chronic. Second, it was done in systolic and diastolic sick patients. So we also had preserved ejection fraction, heart failure with preserved ejection fraction. And within the CADHF trial, there was a signal, significant signal, about a positive impact on the heart endpoints in terms of HFpEF patients. So that might be a totally different field here.
Yeah. And of course, also can HFpEF. So we know, of course, that the prevalence of atrial fibrillation is very high in those HFpEF patients. And maybe this might also explain partly why, particularly in this kind of population, treatment of sleep apnea by different means might be particularly effective. So you also mentioned the ablation strategies like extrapulmonary vein triggers. There are also now, of course, techniques to really modulate the autonomic nervous system by ganglionar plexi ablation. This is, for example, something what is happening now, and a lot of other strategies to modulate the autonomic nervous system. This is certainly also something. And then actually those phrenic nerve pacemakers, which you also mentioned, which particularly for central sleep apnea, right?
Yeah, that's predominantly central sleep apnea. Asking the other way around, what do you think about renal ablation?
Yeah, well, the modulation of the autonomic nervous system, this is, of course, something where we think that the autonomic nervous system might contribute to atrial fibrillation. And particularly during those arousals, the more sleep apnea you have, the more arousal burden you might have during the night. And if, of course, this arousal intensity, for example, can be modulated potentially by renal denervation, potentially by GP ablation, potentially by other means of autonomic modulation, this might be a way to reduce the arrhythmogenic substrate in this kind of population, because, well, I think there's no other condition potentially in humans where you have more sympathetic activation, at least during night, compared to sleep apnea.